All right, welcome back to the deep dive.
Good to be here.
We're jumping straight in today. We've got a bunch of sources, veterinary texts, a study guide too, and we're going to really unpack canine and feline sinus tachycardia.
Yeah, and our goal, it's pretty straightforward. Just pull out what these sources say. What is sinus tachycardia in dogs and cats? Why does it happen, according to this material? And why is understanding why it's so important?
Exactly, everything from these pages.
Mm.
And what struck me right away reading through these is how they describe it as the most common benign arrhythmia. So not inherently dangerous itself.
Right, benign.
But, and this is the key thing you mentioned, understanding it is critical because it's almost always like a flag pointing to something else going on.
Precisely. It's the body ringing an alarm bell, essentially.
Okay, let's get into it. The basic definition first. From the sources, when we say sinus tachycardia, what's actually happening with the heartbeat?
So the sources define it as a disturbance in how the sinus impulse forms. Basically, the sinoatrial node, the SA node.
The heart's natural pacemaker.
Exactly, that pacemaker. It just starts firing faster than its normal rate.
So the starting point, the origin, is normal. It's coming from the right place.
Yep. Originates normally in the SA node. It's just fast.
Got it. Pacemaker's working, just in overdrive. And these sources give us actual numbers, right? Thresholds for what counts as too fast.
They do. Clear numbers.
Yeah.
For dogs, generally, it's over 160 beats per minute, BPM.
160.
But yeah, there are variations mentioned, like toy breeds. Their normal can be higher, so maybe over 180 for them.
Yeah.
Giant breeds, though, they're slower. So over 140 might be tachycardia for them.
Right. Makes sense. Different sizes, different baseline rates.
And puppies, they're really fast normally,
Yeah.
so the threshold for them is way up, maybe over 220 BPM.
Wow, 220. They really are little engines.
They are. And for cats, the general number is over 180 BPM.
Over 180 for cats?
Kittens, again, faster still, maybe over 240 BPM. But there's a really practical note in there, too, about the clinic setting. You often see cats over 180, even 200, just from being at the vet.
Ah, the stress factor, the white coat syndrome kicking in.
Exactly. It's a
Right.
perfect example of physiologic cause right there.
So, okay, we know it's fast, starting normally. How does this actually look on an ECG, that electrical tracing? What do the sources say are the key features?
The ECG shows a rapid rhythm, but it's usually pretty regular.
Fast and steady.
Mostly. You'll see a P wave, that's the atrial contraction for every QRS complex, the ventricle contracting. And that P wave should look like it's coming from the sinus node.
Normal origin P wave.
Right. And the PR interval, the time between the P and the QRS, stays constant, beat to beat.
Okay.
There can be slight variation in the RR interval, the time between beats, but overall, it looks regular.
Like a metronome just set really fast?
Kind of, yeah. And here's a really key detail they highlight, especially at very fast rates. The P wave from one beat can get really close to, or even look like it's merging with, the T wave from the beat before it.
The T wave being the ventricle relaxing.
Exactly. So P wave runs into the previous T wave. Seeing that fusion, partial or complete, is a big clue on the ECG for sinus tachycardia.
That sounds like a subtle but important pattern to spot. Did the sources mention how it starts or stops, like suddenly or gradually?
Yeah, they usually note a gradual onset and a gradual termination.
Yeah.
Which helps tell it apart from some other fast rhythms that can start and stop very abruptly.
Okay, so definition, numbers, ECG appearance.
Yeah.
Check. Let's get to the why, the pathophysiology. Why does that SA node speed up?
Well, the mechanism described is technical sounding, accelerated phase 4 diastolic depolarization of the SA nodal cells.
Which means?
Basically, the pacemaker cells just get ready to fire again more quickly than usual.
Okay.
But the real driver, the thing the sources really emphasize, is the autonomic nervous system, the ANS.
Ah, the body's control system. I like the gas pedal and brake analogy for this.
That's a great way to think about it. The sympathetic system, that's the gas pedal.
Speeds things up.
Right. Releases norepinephrine, hits those beta-1 receptors in the heart, increases rate, increases how hard it pumps, kicks in during exercise, stress, excitement.
Got it. Sympathetic equals go faster. And the brake.
That's the parasympathetic system, the vagal system. Releases acetylcholine, acts on different receptors, muscarinic ones, and it slows the heart rate down. More active when resting, calm.
Okay.
And usually, heart rate changes involve both working together,
Right.
One steps up, the other backs off.
So sinus tachycardia is the gas pedal being pressed harder or the brake easing off or both?
Pretty much, yeah.
Yeah.
And this leads us to what the sources say is the absolute #1 most critical point about sinus tachycardia.
Okay, lay it on us.
It is almost always secondary. It's a consequence or reaction to some other stress, either physiologic, like exercise, or pathophysiologic, meaning disease.
So it's not the heart itself being faulty.
Usually not. The SA note itself is typically fine. It's just being told by outside influences, by the ANS, to speed up. It's a compensatory mechanism.
That is a huge point. It really shifts the whole focus. It's not the primary disease, it's a symptom of the primary disease or stress.
Exactly. And the sources provide this incredibly long list of those potential underlying causes, those stressors.
Right, they break them down. What are the main categories?
First category is physiologic or compensatory. These are often like normal body responses.
Okay.
Things like exercise,
Yeah.
pain, just being restrained, excitement, fear, anxiety, stress, including that vet visit stress, the white coat thing.
Yeah.
Also fever, or just being too hot, hypothermia. Low blood volume, which is hypovolemia or dehydration.
Mm-hmm.
Anemia, not enough red blood cells. Low blood pressure, hypotension, or shock. Low oxygen, hypoxemia. Low blood sugar, hypoglycemia. Basically anything that triggers that big stress response.
Wow, that list alone covers a lot of ground.
It really does. Then there's the pharmacologic or drug-induced category.
Meds or toxins.
Right. Things that can stimulate that sympathetic gas pedal
Yeah.
or block the parasympathetic brake.
Yeah.
The sources list specifics: atropine, epinephrine, ketamine, telazol.
Anesthetics and emergency drugs.
Yep. Also things like quinidine, certain asthma meds like xanthines, beta agonists, thyroid hormones if the dose is too high, causing iatrogenic hyperthyroidism.
Accidental overdose.
Right. And common toxins, caffeine, theobromine, that's the stuff in chocolate.
Ah, chocolate toxicity.
Exactly. Some
Yep.
antihistamines, certain antidepressants, even some plant toxins like Jimson weed or venoms from scorpions or black widow spiders are mentioned.
Jesus. It's amazing how many things can push the heart rate up.
It is. And then the biggest category, pathologic or systemic diseases. This is where you really see it as a compensation.
Okay, the underlying illnesses.
Yeah. Fever, again, often from infection. Congestive heart failure, CHF,
Yeah.
chronic lung disease, shock, fluid around the heart, pericardial effusion, anemia, infection anywhere, hypoxia, blood clots in the lungs, pulmonary thromboembolism, low blood pressure, low volume.
Still going.
Oh yeah, a specific tumor, pheochromocytoma, usually on the adrenal gland, pumping out adrenaline. Hyperthyroidism, super common in older cats. Inflammation around the heart, pericarditis, collapsed lung, pneumothorax, low blood sugar. Certain nerve issues, problems with the heart muscle itself, myocarditis, DCM, HCM.
Dilated and hypertrophic cardiomyopathy.
Right. Sepsis, which is overwhelming infection or inflammation, pancreatitis, kidney failure, liver disease, other adrenal tumors, just general painful conditions like bad arthritis or dental disease, and even rarely severely low potassium.
My goodness. Looking at that list pulled straight from these sources, it just hammers home that the fast heart rate itself is almost always just the tip of the iceberg. It's the body saying something's wrong.
Absolutely. And the vet's job following these principles is to figure out what that something wrong actually is.
So if the tachycardia itself isn't usually the core issue, what might you actually see in a pet? What are the clinical signs, the physical exam findings?
Well, the sources are really clear on this. Often there are no specific signs just from the tachycardia itself.
Which makes sense if it's just a response.
Exactly. The signs you see are usually tied to whatever's causing it, the underlying stressor or disease.
Okay.
However, if the tachycardia is really severe or goes on for a long time, it can start to affect how well the heart works, especially if there's already some heart disease there.
Right.
In those situations, you might see signs like weakness, not wanting to exercise, maybe even fainting spells, syncope.
Because the heart's beating so fast it can't fill properly, reduces output. The sources mention that, right? Fast rate shortens filling time, especially bad and diseased hearts.
That's exactly the mechanism they describe. Less filling time, less blood pumped out, compromised cardiac output. Other signs are more about the underlying cause. Breathing fast or with difficulty, being restless, panting, seeming really tired, not eating well, losing weight. Classic with hyperthyroid cats, maybe vomiting or diarrhea, coughing or collapsing.
And what about the physical exam, besides just feeling that rapid pulse?
Well, the main finding is that fast heart rate you can feel or hear. If it's just, say, excitement tachycardia, the sources say the rest of the exam might be totally normal.
Okay.
But otherwise, the findings depend entirely on the cause. Maybe pale gums from anemia or bad heart failure, a fever, signs of CHF like a cough, maybe that bluish tinge, fluid in the belly. You might hear a heart murmur or an extra heart sound, a gallop. crackles or wheezes in the lungs, maybe feel an enlarged thyroid in a cat that thyroid slip, signs of belly pain, dehydration. It's all about looking for clues to the primary problem.
It really paints a picture of detective work, with the fast heart rate as the first big clue. So how do vets, using these source guidelines, actually nail down that it is sinus tachycardia, and then the crucial part, figure out the why?
Okay, the diagnostic path screech, as always, with a really good history from the owner and a thorough physical exam. That gives you the initial hunches.
Gathering clues.
Exactly. Then, the ECG is absolutely essential. That confirms its sinus rhythm, coming from the right place but fast. And just as importantly, it helps rule out other kinds of fast heart rhythms.
Ah, right, the differential diagnosis. What other fast rhythms look similar but aren't ST?
You've got to distinguish it from other supraventricular tachycardias SVTs. These also start above the ventricles, but not in the SA node, like atrial tachycardia or AV junctional tachycardia.
Okay, other fast rhythms from the top chambers.
Right, and then there's ventricular tachycardia, VT, which starts down in the ventricles, and atrial fibrillation, AFib, which is fast but really chaotic and irregular.
So the ECG helps sort those out. Are there other tricks or maneuvers mentioned in the sources to tell ST apart from, say, those other SVTs?
Yeah, they list a few specific things. One is doing vagal maneuvers.
Stimulating that brake nerve.
Exactly. Gentle pressure on the carotid sinus in the neck, or carefully on the eyeballs. With sinus tachycardia, this usually only causes a gradual temporary slowing, if anything. But with an ectopic SVT one starting elsewhere, a vagal maneuver might actually stop the rhythm completely, abruptly.
Ah, different response.
Yeah, and the sources note that with ST, a vagal maneuver might sometimes cause a temporary heart block on the ECG, like a first-degree or specific type of second-degree block called Wenckebach. The signal gets slowed down briefly.
So you're essentially testing the system. Does it respond like the normal pacemaker pathway or like something abnormal?
That's the idea. Another thing mentioned is a precordial thump, a quick rap on the chest. Sources say ST won't change. Some other SVTs might pause for a beat or two.
Interesting.
And they also mention, as a diagnostic thought, a pharmacologic trial, like giving IV diltiazem, a calcium channel blocker. If it's ST, probably minimal effect. If it's another SVT, it might stop it.
Fascinating bedside diagnostic tools. Okay, so you've confirmed it's ST. Now, finding that underlying cause, what tests do the sources point to?
The sources really stress that your test choices depend on what you suspect based on the history and exam, but blood work is almost always done.
The basics.
Right. CBC, chemistry panel, urinalysis, looking for anemia, that low PCV, packed cell volume signs of infection or inflammation in the white cells, kidney or liver problems, electrolyte issues, blood sugar. The works.
Gives you a broad system check.
Exactly. Thyroid tests are key, especially in cats. Measuring T4, maybe free T4. There are more advanced thyroid tests mentioned too, like suppression tests or scintigraphy for tricky cases.
Okay, thyroid's covered. What else?
Imaging, chest x-rays, thoracic radiographs to look at the heart size, the lungs for CHF or other issues. Echocardiogram, heart ultrasound if you suspect heart muscle disease like DCM or HCM or valve problems.
Seeing the heart structure and function directly.
Abdominal ultrasound, maybe CT or MRI if you're worried about something in the belly, like pancreatitis or maybe that adrenal tumor, the pheochromocytoma.
Systematically checking the likely suspects based on the clues.
That's the plan. Other tests mentioned: blood pressure, pulse oximetry or blood gas to check oxygen levels, NT-proBNP, that blood marker for heart stretch. Sometimes Holter monitoring wearing an ECG recorder for 24 hours or more. And then really specialized stuff like electrophysiologic studies or checking catecholamine levels in the blood or urine, though the sources say those have some limitations.
A whole toolkit depending on where the clues lead. What about post-mortem? Any specific findings just from ST?
Sources say typically no, not if it was just physiologic or drug-induced. Any findings would relate to the primary disease that was actually causing the tachycardia.
Right. Okay, this is all leading to the big question. Treatment. We figured out it's ST, maybe found the cause. What do we do about it, according to these sources?
And here we hit that core principle again, loud and clear from all the material. Treatment is aimed squarely at the underlying cause. You don't typically treat the sinus tachycardia itself.
That really seems to be the mantra for this condition. Fix the root cause.
It absolutely is. Because if you fix the primary problem, you remove the reason the SA node was firing so fast, and the heart rate usually comes back down on its own. The sources give loads of examples based on the cause. Pain, give pain meds, analgesia,
Makes sense.
anxiety, stress, calm handling, maybe sedatives like gabapentin or trazodone mentioned in the study guide, low blood volume, AV fluids, anemia, blood transfusion, low oxygen, give oxygen, fever, treat the infection, maybe antipyretics.
Address the specific issue.
Exactly. Hyperthyroidism, meds like methimazole or radioactive iodine or surgery, CHF, diuretics, pimobendin, ACE inhibitors, maybe digoxin in specific cases like CHF with AFib or CAT DCM, fluid around the heart, pericardial effusion, drain at pericardiocentesis. Sources specifically say avoid rate control drugs there.
Just get the fluid off.
Right. Drug-induced tachycardia. Stop the drug or lower the dose. Pheochromocytoma tumor. Surgery is the goal.
So it's almost always about tackling that primary issue, which leads to the question, when would you even consider drugs just to slow the rate? Beta blockers? Calcium channel blockers? The sources mention them but sound really wary.
Extremely wary. This is where the sources draw a very firm line. Specific antiarrhythmic drugs just to control the rate. They say that's generally limited to very specific situations.
Like what?
Basically, patients already in CHF or those with secondary heart issues caused by something else like severe hyperthyroidism or hypertension that you're still getting under control.
Okay, so not just because the rate's high. There has to be more going on.
Definitely not, just because it's high. And the warnings are strong. Rate control drugs should only be considered if the super fast heart rate itself is actually causing harm, like it's so fast the heart muscle isn't getting enough oxygen, myocardial ischemia, or it's making existing CHF much worse, and you can't fix the underlying cause right away.
That sounds like a very narrow window and a judgment call made with extreme care.
It is. The sources are explicit. Using these drugs wrong can be really bad. They can drop blood pressure dangerously low, reduce blood flow to organs, make weak heart muscle function even weaker. They're generally contraindicated, meaning shouldn't be used if the animal is in shock from low volume or in severe CHF before you get the fluid overload handled, especially in dogs, or if there's already high vagal tone, high brake activity.
So lots of reasons not to use them.
Absolutely. The sources mention examples like diltiazem, atenolol, sotalol, maybe digoxin with dosages, but purely as examples used in these rare specific veterinary decisions. And you definitely avoid drugs that increase the rate, like atropine, obviously.
Okay, so let's hammer this home based on the sources. Priority 1, 2, and 3 is treat the underlying cause. Using drugs just to slow the rate is a fallback, reserved for when the rate itself is actively dangerous and done very, very cautiously with full awareness of the risks.
That is the absolute essence of what these sources convey about treatment. They also mention supportive care, like tailoring nursing to the main disease, maybe restricting exercise with heart disease, sometimes low-sodium diets for hypertension or CHF, and educating the owner is key.
Makes sense. What about the outlook, the prognosis for a pet with sinus tachycardia?
Sources say it's generally good to excellent such a, if you can find and successfully treat the underlying cause.
It all comes back to the why.
Always. The prognosis really just mirrors the prognosis for whatever primary disease was driving the tachycardia. Poor if it's tied to severe end-stage CHF, often favorable for something like hyperthyroidism once you get it managed.
And prevention or complication.
Prevention is mainly about minimizing stress, maybe exercise or sodium if there's known heart disease. Complications from the tachycardia itself could be weakness or fainting if it's really severe and impacting output, or potentially contributing to the worsening of CHF if it persists alongside heart disease.
Got it. One last area the study guide source mentions specific points about anesthesia. That seems crucial.
Hugely important. The sources emphasize doing a thorough pre-anesthetic check. If the animal already has tachycardia before going under, you really want to figure out why is it pain, anxiety, dehydration, and ideally, address those things first. Get the pet stable before inducing anesthesia.
It makes the whole procedure safer.
Absolutely. Then, during the procedure, constant monitoring is key: heart rate, rhythm, blood pressure. If tachycardia pops up during anesthesia, the sources list things to check immediately. Is the anesthesia too light? Pain? Low blood volume or pressure? Low oxygen or high CO2? Body temperature off? A reaction to a drug?
So even under anesthesia, that fast rate is still a signal to more to get a gystigate.
Exactly. And again, the caution about rate control drugs applies here too. Use them during anesthesia only with extreme caution after ruling out those other causes, because they can tank blood pressure or mess with the body's ability to compensate.
Wow. Okay, this has been a really thorough exploration, pulling directly from these sources on canine and feline sinus tachycardia. We've covered what it is, the ECG clues, especially that P-wave fusion. the incredibly wide range of potential causes and really hammered home that core principle. Treat the underlying problem first, with rate control being a very specific, cautious intervention.
It really does show how something seemingly simple, a fast heart rate, is often this vital signpost pointing towards a much bigger picture in the animal's body. It's all connected.
It is. So here's something for you, our listener, to think about. What does this whole deep dive into sinus tachycardia really tell us about just how important careful observation is, and always asking why? Why is this happening? How does shifting perspective, seeing that fast heart rate, not as the problem, but as a potential symptom of maybe dozens of other things, change how we think about veterinary diagnostics or even just watching our own pets day to day?
It definitely highlights that detective work aspect of medicine, finding the real story.
Absolutely. We hope this journey through the source material has given you some valuable insights. Keep questioning, keep exploring those fascinating details in veterinary medicine.